Before we begin, I would like to review a little bit of the anatomy before we get into junctional rhythms. The first thing I would like to discuss is the primary pacemaker of the heart, which is the SA node, also known as the sinoatrial node. The sinoatrial node has an intrinsic rate of 60 to 100 beats a minute. If the SA node were to fail, the backup pacemaker is the AV junction. The AV junction has an intrinsic rate of 40 to 60 beats a minute, and the tertiary pacemaker, or the backup to the backup pacemaker, is the Purkinje network, or the Purkinje fibers. They have an intrinsic rate of about 20 to 40 beats per minute. Next, we're going to review a little bit of the electrical system itself. When it comes to the electrical system, some of the things I want to point out here are this. We have the SA node up here in the right atrium, and then we have the AV node down here that's also located in the lower portion of the right atrium as well. One thing I would like to take note is the three internodal pathways that occur between the SA node and the AV node itself. After you have the AV node, then you get into the His bundle. As you can see, the His bundle right here. The purpose of the His bundle is to bypass the atrioventricular septum. There is a non-conductive wall that goes between the atria and the ventricles right here, and the His bundle is responsible for going through that atrioventricular septum. Once it gets through that, the next thing the electrical system does is bifurcate into the right bundle branch and then the left bundle branch, which then bifurcates into the anterior and posterior fascicles. One thing I would like to note is, as you see over here for my class, all of these different intrinsic rates, depending on how far down you go, you don't have to worry about those. I'm not really interested in every single one of these, so don't worry about each one of these intrinsic rates. The intrinsic rates that I just gave you, the SA node is 60 to 100 beats per minute. The AV junction, which is the His bundle and the AV node, has an intrinsic rate of 40 to 60 beats per minute. And then the Purkinje network are all these little fibers that you see down here. The Purkinje network is 20 to 40 beats per minute with their intrinsic rate. Let's talk a little bit about the junctional anatomy itself. When you consider the junctional anatomy, just remember that the area around the AV node can be just as important as the AV node itself. The AV node is comprised of three different zones or areas that cover the AV node. There's a transitional zone, a compact zone, and a final or trigger zone. Now, we're going to cover each one of these zones, so don't think that I'm just going to leave you hanging. Also, there are two approaching tracts. There's an anterior-superior tract and there's a posterior-inferior tract. I'm not really interested in learning or teaching the actual term, the anterior-superior and the posterior-inferior tract. If you want to learn those, that would be great. I'm more interested in making sure that you recall the fast tracts and the slow tracts, and I'll explain what each one of those means. So first, let's talk about the three zones. Remember, there's a transitional zone, there is a compact zone, and then there is a final or trigger zone. So I want to talk about each one of those zones. The first zone around the junctional anatomy is considered the transitional zone itself. In the transitional zone, this is the small amount of tissue that's actually located at the top or the tip of the AV node. And basically what it does is it covers the AV node. So if you think of somebody that has a Q-tip, you have the white shaft of the Q-tip, and then you have the Q-tip itself has the fuzzy part that covers the Q-tip. The transitional zone is like the fuzzy part that covers the Q-tip. And as you can see, the transitional zone is just this part that actually covers the outside of the compact zone. Now, the transitional zone is important because it's very full of autonomic fibers. And what autonomic fibers are fibers that are very arrhythmogenic, which means they have the ability to depolarize early and potentially cause premature junctional complexes or anything like that. The next area I would like to cover is the compact zone. The compact zone basically is the core, or this area right here, of the AV node itself. The core of the AV node is very important because it is histologically similar to the SA node. And what that means is when we talk about histology, we talk about the tissue and what the tissue is comprised of. In this case, the tissue in the compact zone is very similar to the tissue in the SA node itself. So if the AV node becomes the pacemaker, usually this is the area that can become the pacemaker, which is the compact zone. Another very important function of the compact zone is that this is where the signal is slowed. So as the signal comes down through the fast or the slow tract, once it gets down here, the signal has to slow way down to get through the compact zone. And the reason it slows down is to allow for atrial contraction. If a person were to just allow the signal to rifle through at a normal rate, it could cause ventricular and atrial contraction at the same time. So the transmission is slowed down through the compact zone to allow for atrial contraction. The last part I would like to discuss is the final, or the trigger zone. It can be called either one of them. I've heard them both. The last part, it's not really labeled here on the picture, but the last part of the junctional node here is the trigger zone, which is down in this area here. This is where, as you remember, the signal is slowed down as it comes to the compact zone to allow for atrial contraction. Once it gets down here to this trigger zone, then the signal speeds up again to depolarize the His bundle, the bundle branches, the posterior and anterior fascicles, and then the Purkinje network very quickly. This is also the place where the His bundle begins and the AV node ends. The problems that we run into with this kind of stuff is when it comes to the junction as a pacemaker, if the impulse originates, we'll just say the impulse originates anywhere down here, what can happen is the signal can travel up in this direction and it can also travel down in that direction. What that will do is it will cause alterations in the depolarization of the heart and how you see it on the monitor itself. Therefore, if you have a depolarization that occurs down here somewhere and it travels this way up in the opposite direction, up in this direction here, if you're looking at lead 2, and we'll pretend that this is lead 2, if you're looking at lead 2, any signal or impulse that travels away from the positive electrode, which in lead 2, this would be the positive electrode, if it travels away from there, then that means that you're going to have a negative deflection on the monitor. So this is where the negative deflection comes from whenever you have a junctional rhythm or a premature junctional complex, either one. As you can see here, when the P wave, where the P wave is located, is kind of proportionate to where the impulse occurs. So if the impulse occurs out here, the premature impulse, it's possible that you could have a P wave that occurs early enough before the QRS where it's easily identifiable. The closer you get to the transition zone and the compact zone, and in some cases, like over here, even further down into the His bundle, kind of depends on where the P wave is in relation to the QRS complex. So if you have a P wave that occurs extremely close to the QRS complex, it was closer down here to the compact zone. In this case, if you have a P wave displaced behind the QRS here in this ST segment, then it was probably past the AV node and the signal had to travel backwards up through the slow part of the AV node before it could actually get up here and depolarize the atrium. What that does is this signal travels down first, causing the QRS complex first. As the QRS is occurring, then the signal slowly travels up through the AV node, and then it depolarizes the atrium. In previous presentations, if you remember, we talked about the P wave and what it actually represents. The P wave, in the perfect world, represents SA node depolarization. Unfortunately, this is not always the case. Ideally, the P wave represents atrial depolarization. Because of this is the correct interpretation of what a P wave is, makes it hopefully better understanding that this right here, this P wave here, is not an SA node, but it is atrial depolarization. Let's talk a little bit about junctional escape rhythms and junctional escape beats. An ectopic area can do a couple things. And what do I mean by an ectopic area? An ectopic focus is any depolarization that occurs outside of the normal depolarization process. So if you have somebody, and I'm just going to draw a heart over here right quick, you have the SA node up here, your internodal pathways, your AV node, and then your His bundle and your bundle branches, and then the fascicles. If you have an ectopic focus that occurs right here, this is what makes it ectopic. It occurs outside of the normal depolarization process of the heart. So an ectopic area can either cause an escape beat or it can set off an escape rhythm. An ectopic focus can also not just cause an escape beat, but it can also cause a premature beat, which will occur early in the cardiac cycle. So let's look at exactly what a junctional escape beat might look like. This would be an escape beat, which means the escape beat occurs after the normal cardiac cycle. So what happens is we'll look at each one of these beats right here. That's your P, Q, R, S, and T wave. Then we have another one here, and another one here, and another one here as we go down. As you can see here, we have a normal R to R interval. The next expected beat is supposed to occur here, but it does not. Therefore, we end up with a junctional escape complex. How can you tell if this is a junctional escape complex? Well, first of all, it's an escape beat because it occurred after the normal cardiac cycle. As you can see here, it occurred after the normal cardiac cycle. How do I know it's junctional? Well, as you can see here, in every other one of these areas here, there's a P wave that occurs before the QRS complex. There is no P wave that occurred before the QRS complex. Another note that you want to be very careful about is if you look at each one of those QRSs, what you will actually see is that, not looking at the P wave, but if you look at the QRS and T wave, every single one of these QRSs and T waves occur almost the exact same. What that tells me, that if the QRS is the same, then in this case the problem is above the ventricles. If the QRSs were different, then the problem would be in the ventricles. But since they're all the same all the way across, then the problem is above the ventricles. And since there's no P wave right here, that tells me that this is a junctional escape complex. So let's look at a junctional escape rhythm right now. If you have just one complex, it's just a junctional escape complex or junctional escape beat, as it were. Now we have all of these QRS complexes coming across here, and they all look the exact same. If you look at the QRS and T wave, they all look the exact same. But what exactly are they missing? They are missing the P wave in every single one of these complexes. That tells me that the originating beat is occurring somewhere in the junction itself. Why would it not be occurring in the ventricle? I do get that question frequently. Why is this not considered a ventricular escape rhythm? One reason is because we're talking about junctional rhythms, so it could be a junctional rhythm. Realistically, though, If this were a ventricular escape rhythm, the QRSs would be greater than 0.12 second. They would also be wide, bizarre looking, without steep points, without narrow angles. In this case, these all are narrow, steep angles with sharp points, which tells me that the origin of that rhythm is above the ventricles. The junction technically would be classified above the ventricle, like the AV node. The second rhythm down here I want you to take a look at very carefully. In a previous presentation, our atrial rhythms, one of the things I discussed was to identify an atrial rhythm you look for an erratic baseline. As you can see in this rhythm down here, there is a very erratic baseline. The problem that we run into with not being able to distinguish junctional versus atrial rhythms is if you don't follow the interpretational process. Atrial fib, the regularity is irregular. If you were to look at this junctional rhythm here, would you say that this rhythm is regular or irregular? In this case, it's regular. So it's very important to follow your 6-step interpretational process. Do not use an erratic baseline as your definitive diagnosis to find atrial fib, because you could have a junctional rhythm with an erratic baseline and people misdiagnose it all the time. Let's look at the junctional escape rhythm characteristics. The rate typically is 40 to 60 beats a minute, and that's an intrinsic rate. It's going to be pretty regular. If there's any irregularity to it, then you might have to look at maybe there's some other something going on. Typically, though, it's very regular. P waves, they could be absent or they could be inverted, but most of the time, not all of the time, they are before the QRS if they are present. The P to QRS ratio, if they're absent, then it's not applicable. If it's inverted, it would usually be a 1-to-1, but that doesn't mean that you're going to have P waves all the time. The PR interval is usually less than 0.12 second if it is actually present. So the PR interval typically is shortened. The QRS width, because this is a problem above the ventricles, the QRS is going to be normal or wide. Let's look at our first rhythm here. Let's follow the interpretational process. We have atrial and ventricular rates. Do I have an atrial rate? Well, technically I do, and let's pretend that this is a 6-second strip. So I can do it one of two ways. I can count my P waves. So this could be a 1, 2, 3, 4, 5. In this case, the arrow in this particular book, that is a P wave right there. I'm not expecting people to identify that right away. Most people would look at this and just say, that's not a P wave, that could be artifact, it could be something else. If you don't identify it, that's fine. But if you do, that's fine also. I definitively know that each one of these guys here are P waves. If I use my 6-second method, I could comfortably say that my rate is 50 beats per minute. There's another way that you can interpret this. You can put a range. I've discussed ranges before, and I am more of a fan of putting a range of the atrial rate or ventricular rate if it's irregular, because it gives you a better idea. The reason I say that is I want to go back to an example I might have used earlier. If you have a range of 70 to 80 beats per minute, that average is 75 beats per minute. Although, if you have a range of 50 to 100 beats per minute, what's your average? 75 beats per minute. I've always been a bigger fan of putting a range because I would be more concerned about a patient that has a 50 to 100 beat range compared to a 70 to 80 beat range. If somebody has a heart rate that's ranging between 70 and 80, it might just be normal for them. If it's ranging between 50 and 100, to me, that's too much. and just putting the average of 75 might imply the patient is perfectly fine and there's no need for further treatment. If you were to do a range on this rhythm, what you would want to do is count all the little boxes between the two P waves. So in this case, it would be 5, 10, 15, 20. We'll say about 23 little boxes, which is about 65 beats per minute, if I counted correctly. Then you would take the widest QRS, or I'm sorry, the widest atrial rate, and in this case 5, 10, 15, 20, 25, 30, 35, 40, 45, 50, and we'll just say 55 for simplicity, which gives me a rate of 27 beats per minute. Either one of these answers would be correct. If you put 50, I would probably take it because there's 5 P waves. But 65 to 27 beats per minute is what your atrial rate would be in this case. So let's just go ahead and keep it with the 6-second method just for the sake of time. What is our ventricular rate? Well, if you count 1, 2, 3, 4, 5, 6, you would say that the ventricular rate is 60 beats per minute. Is it regular or irregular? We're going to identify this as irregular. P waves are present and married except at this beat right here. And you can identify it as the 1, 2, 3, 4, 5th beat, or you can identify it as present and married except at the escape complex, because we should really be calling them complexes, not beats, so that should really be complex. But either one is usually acceptable. They're not all present and married. I will let you know now, if you put just present and married and you don't put any other information, so let's say that you put present and married only, and we'll take all this out, I will tell you now that I will mark that wrong on your homework because they're not all present and married. The PR interval. Well, if we look at the PR interval, I don't have calipers on me, but it looks like it's 1, 2, 3 little boxes maybe, 1, 2, 3, maybe 4 little boxes. So when it's present, it is 0.16 second. The QRS complexes, like I said, I don't have calipers, so I can't really tell, but I'm going to say that they're 0.10 second. So, don't need to put that there. What is the overall interpretation? First thing you want to do, like I discussed in the atrial rhythms, the first thing you want to do is interpret the underlying rhythm. This here is the anomaly, not the underlying rhythm. So the underlying rhythm is sinus rhythm, or if you use our rate up here under the atrial rate here, you could say that it's sinus bradycardia. Don't put both of them like I did. You have to pick one. So sinus rhythm or sinus brady with, now what is the anomaly right here? There's no P wave, so we know that it's going to be a junctional beat. We just don't know. Is it premature, or is it an escape beat? Is it premature or is it escape? It is an escape beat because the next predicted beat should have been right about here, but it didn't occur, so it occurred after the cardiac cycle. So this would be a sinus rhythm with junctional escape complex. Let's look at the next rhythm. What is our atrial rate? We'll pretend this is lead 2 and a 6-second strip. Our atrial rate, we have 1, 2, 3, 4, 5, 6, 7 P waves. So we can just, for time's sake, we'll just put 70 beats per minute. So I'll say the atrial rate is 70. What is the ventricular rate? 1, 2, 3, 4, 5, 6, 7, and a little bit more, so I would maybe say 75 just to make it easy. It's not quite 80 because we don't have a full QRS and T wave back here, so we'll just call it 75 for now. Is it regular or irregular? Hopefully you notice it was irregular, because if you march this out, this right here automatically tells me that it's irregular. P waves. Is there a P wave before every QRS, and is it married to every QRS? So yes, it is present and married, except at 1, 2, 3, 4, 5, 6, the 7th beat, or the 7th complex. PR interval actually looks a little bit wide, so if I had some calipers I could probably do this better. So that looks like 1, 2, 3, 4. So it's right about 0.20 second, and the QRS looks to be about 0.08 second. So we do have a problem with it, but we first have to identify the underlying rhythm. What is the underlying rhythm? In this case, the underlying rhythm is a sinus rhythm, but it has a problem. It has a junctional escape complex. Let's start off with our atrial rate. In this case, the book was nice enough to show us that that little divot right there is that little hole or depression right there is probably the P wave is retrograde to the QRS complex, and that basically means behind in this case. In this case, it's behind the QRS complex. The book says that this is a P wave. Now we know it's a P wave. But let's say that you didn't actually have that. Let's say that when you were looking at this rhythm here, you didn't have that nice, cute, petite little arrow right there to tell you that that's a P wave. What that means is I would be okay with you not being able to identify this as atrial rate. So if you don't have an atrial rate, you can just put none, or in this case you can put unable to obtain because we don't know where it is. If this were a 6-second strict in lead 2, I would say let's do the 6-second method, and we would say that the ventricular rate is 40 beats per minute. Is it regular or irregular? It is regular. Like I said, I'm doing this by eyeballing. I can't do it with calipers on my computer, so I'm assuming that it's regular. It looks regular. P waves. If you did not know that was a P wave behind it, I would say it's okay to call the P wave absent. PR interval. If you don't have a P wave, you can't have a PR interval. QRS complex looks nice and narrow, and it's steeply angled with sharp points. And it is 0.08 second. So what is my interpretation? This wouldn't be a junctional escape complex. This would actually be a junctional escape rhythm. Remember, a junctional escape rhythm, the intrinsic rate is 40 to 60 beats per minute. If it were slower than 40 or faster than 60, it would be something different, which is what we'll talk about later. Now let's discuss the premature junctional complexes. Premature junctional complexes are different because they are premature rather than escape. An escape complex occurs late in the cardiac cycle. Premature complexes occur early in the cardiac cycle, or the R to R interval. Typically, they'll have absent or inverted P waves in the inferior leads. They can occur without any kind of cardiac contraction, which increases the automaticity of the AV junction. There is no clinical significance with isolated PJCs. That basically means people can throw PJCs and live perfectly healthy lifestyles with no cardiac compromise whatsoever. A premature junctional complex will occur early in the cardiac cycle. As you can see here, this is the PJC. There's no P wave in front of it, so you can't call it atrial or junctional. But if you look at the QRS and the T wave of each one of these complexes, don't look at the P wave, look at the QRS and the T wave. If you look at them, they are all the exact same, which tells me there is nothing wrong with the ventricles. It is all supraventricular or above the ventricles. I've had people in the past ask me, how do you distinguish between a PJC, which is a premature junctional complex, and a PAC, which is a premature atrial complex? The best answer I can give you, outside of looking at hundreds and hundreds of rhythms, is you want to start at the QRS complex of the premature complex. Then you want to look backwards on the rhythm strip at the T wave before, at the previous T wave. As you can see here, if you look at, this is going to be rhythm 1, and down here is going to be rhythm 2. If you look at rhythm number 1 up here, if you look at the PJC here, and you start looking backwards, you come up to this T wave. Now, does this T wave here look the same as this T wave here? Yes, it does. Does it look the same as that T wave? Yes, it does. It looks the same as this T wave. What that tells me is that there was no P wave or any atrial contraction in this T wave at all. So there's no extra depolarizations in there, which tells me that this is a junctional complex. Junctional complex. On the other hand, if we look down here at rhythm 2, start with the QRS and start looking backwards. If you start looking backwards on this QRS here, you come to the T wave. Now, does this T wave look like this T wave back here? No, that's a second morphology. That's T wave looks like that one up here. The next one looks that one there. So you can see that this T wave here is different. Because this T wave is different, that tells me that there's a P wave buried somewhere in there. If there's a P wave buried somewhere in there, that means that you have atrial complexes. You have atrial depolarizations that are occurring during the T wave. Now let's interpret some rhythms. Let's consider our atrial rate. We have P waves here, 1, 2, 3, 4, 5. I don't see a P wave here, 6, 7. So I have an atrial rate of 70 beats per minute. Let's look at our ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8. So our ventricular rate is 80 beats, 80, not 8, beats per minute. Is it regular or irregular? Well, it's going to be irregular because of that particular complex right here. P waves are present and married except at the 1, 2, 3, 4, 5, 6th complex. PR intervals. If you look at the PR interval, it looks to be about 1, 2, 3, 4. So 0.16 second. The QRS complex that occurs looks like it's 1, 2, maybe 3. So we're kind of pushing the border here. So it's 0.12 second. The interpretation, always interpret the underlying rhythm first. The underlying rhythm in this case would be a sinus rhythm based on the atrial rate up here. Sinus rhythm with a premature junctional complex. How do I know it's junctional? Ideally, I would look at every single one of these T waves and see if there's an extra depolarization in each one of these T waves. It looks like there's supposed to be an extra depolarization in there, but there's not. There's not supposed to be, but it might look like it. It might be easier to look at some other rhythms, but ideally that's a premature junctional complex. Let's look at this one. What is our atrial rate? 1, 2, don't know what's going on here. 3, 4, 5, 6. So I know there's an atrial rate of 60 beats per minute. What about my ventricular rate? 1, 2, 3, 4, 5, 6, 7, 8. So I know I have a ventricular rate of 80 beats per minute. So there's a discrepancy there. Is it regular or irregular? I would say it's irregular. P waves. They are present and married, except at which complexes? Looks like the third one, 4, 5, 6, and the 7th one. The PR interval, let me see if we can figure it out here. 1, 2, about 3.5, so we'll say about 0.14 second. QRSs, they're nice and narrow, steeply angled with sharp points, and about 0.08 second. The underlying rhythm. What is the underlying rhythm? And that would be a sinus rhythm, but we do have some irregularity here, so we have to identify why is it irregular. Looking at this QRS complex, does this T wave look close enough to that T wave? It really does. It doesn't look like there's an extra P wave buried in there. Even though it is not an exact duplicate of the previous ones, doesn't necessarily mean that there's extra stuff in there. So in this case, these P waves are not buried anywhere in these T waves. There's no extra P waves buried in there. This one here does look kind of like a P wave, but what we're looking at here is that T wave there just got shortened because that QRS complex came out of nowhere. So because the QRSs look about the same as every other one, and there's no extra depolarization in the T wave, we're going to call this a premature junctional complexes. In this rhythm, we have an atrial rate of 1, 2, 3, 4, 5, 6, 7, 8, 9. So we'll say our atrial rate is 90 beats per minute. The ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So our ventricular rate is about 100 beats per minute. Regular or irregular? Well, with this premature complex right here, it's going to be irregular. P waves are present and they are married. If you look at each one of the P waves, they occur before the QRS complex, except at this complex right here, which is the 1, 2, 3, 4, 5, 6, 7th complex. PR intervals, you have a huge P wave here, but let's just look at the PR interval itself. So we have 1, 2, 3, about a 0.12 second, even though that P wave is huge. The QRS complexes look very narrow, so they look like they're 0.08 second. The interpretation, first we identify the underlying rhythm. The underlying rhythm is a sinus rhythm because it's at 90 beats a minute, but we do have a premature complex here. What the arrow is pointing out is this thing right here is the retrograde P wave. There is a P wave back there. If you can identify that as a P wave, then that might actually change your atrial rate. But if you don't identify it as a P wave, that's perfectly fine too. This QRS does look different than all the other QRSs. The book I got this from identified this as a premature junctional complex. Other people might identify this as a premature ventricular complex, which we haven't covered yet. But for today's sake, for this purpose, just understand that the book identified that as a PJC. The next one, we have an atrial rate of 1, 2, 3, 4, 5, 6, 7. So we have an atrial rate of 70 beats per minute. Next, we have our ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have a ventricular rate of 90 beats per minute. Regularity, we're going to say it's irregular. P waves are present and married, except at the 3rd, 4, 5, 6, 7, and 8th complexes. PR intervals, when they are present, look to be about 1, 2, 3, maybe 4, so 0.16 second, which is normal. The QRS complexes, when they're normal, are about 0.08 seconds when they're normal. The interpretation, first thing you want to interpret is the underlying rhythm, which in this case is a sinus rhythm, but it's with this other weird stuff that's going on. This is another one of those rhythms in this book they identified as premature junctional complexes. We just have to go with it because I have to use this particular book for the presentation in the course. So We'll just call these PJCs. You will get better examples of these as time goes on in the course. So we will call these, whoops, PJCs. The next rhythm, and the last one we're going to interpret before we move on to some other information. These are, atrial rate is 1, 2, there's nothing here, 3, 4, 5. So we'll say our atrial rate is 50 beats per minute. The ventricular rate, 1, 2, 3, 4, 5, 6, is going to be 60 beats per minute. Is it regular or irregular? It's irregular. P waves are present and married except at the third complex. Whoops. PR intervals, when we have a PR interval, looks to be about 1, 2, 3, 4, so 0.16 second. QRS complexes look nice and narrow, so I'm going to say 1, 2, so 0.10 second. Looks like it goes a little bit over the 0.08. Interpretation, always interpret the underlying rhythm first. In this case, the atrial rate appears to be 50 beats a minute. So if you put sinus Brady, I would accept that as far as homework in my class. But it is irregular, and you have to identify why it's irregular. In this case, this third complex right here kind of threw us for a bit of a loop. So what exactly is the problem here? There's no P wave in front of it, but the QRS and T wave look exactly the same all the way across. So we're going to identify this right here as a premature junctional complex. The next subject I would like to speak about is an aberrantly conducted PJC. The reason I like to cover this material is because there are a lot of people who use the term aberrancy because they've heard it and it sounds really fancy whenever you're looking at a rhythm. I would like to discuss what exactly an aberrancy is and where it comes from. So when we talk about an aberrancy, it is very easy to confuse an aberrancy with a PVC. They are not one and the same. They both can have wide and bizarre looking QRS complexes, but they actually have different origins. What happens in an aberrancy is the impulse hits an area of refractoriness, usually in the right bundle branch. Now, what I mean by an area of refractoriness is this is an area that is in an absolute refractory, period. What that means is the impulse hits an area that has not yet repolarized to a point where it can respond to an impulse. That ends up blocking the area in the right bundle branch signal. Therefore, this signal will have to travel around the ventricular myocardium from myocardial cell to myocardial cell. This signal is very slow to transmit because you have to account for muscular contraction. So let's look at an aberrancy. First thing, to identify an aberrancy, what you need to do is you need to look at the first few milliseconds of the normal complex and the aberrant complex. So what you're going to do is you're going to look at the first few milliseconds of the normal complex and the first few milliseconds of the aberrant complex. Now, if you were just to look at this on the rhythm, it would look like that this would be a normal sinus beat or normal sinus rhythm, and this over here would probably be a PVC. But if you look at this area here and this area here, they are both traveling upwards in the same direction with the same angle. And that tells me that this is not a PVC, but an aberrancy. What does this mean about what's going on in the body? What that means is if you have, we'll say that this is your AV node. After the AV node is the bundle of His, and I'll just put BOH for bundle of His, And then you have the right bundle branch and then the left bundle branch that actually bifurcates into the Purkinje network or down into that kind of stuff. So what happens is when an impulse travels through this area here, all of the cells depolarize. Now, cells have an all or none property of depolarization. What that means is if a cell reaches threshold, it will depolarize. So either a cell completely depolarizes or it does not completely depolarize. A cell does not partially depolarize in this situation. As you have an impulse that comes through here and depolarizes everything, all of the cells will depolarize. When all the cells depolarize, do all of the cells have the same threshold? And the answer is no. So what happens is when all the cells depolarize, these cells, and I'm going to use this signal here, this little picture again, not all the cells will depolarize at the same threshold. Some cells depolarize up here, some cells depolarize down here, some cells depolarize way up there. The impulse that comes through is strong enough to depolarize all of the cells. But these cells that have a lower threshold will depolarize first. These cells that have a higher threshold will depolarize last. They all depolarize, but some depolarize before others. What that means is which cells are going to repolarize first. Obviously, the cells that depolarize first are going to repolarize first. What that does is it creates this checkerboard, as it were, of cells that are in a relative refractoriness. So as the next signal comes down, it's going to have to slowly migrate its way through all of these repolarized cells. What is it doing in the meantime? It's re-depolarizing those cells. What happens is eventually the signal is going to try to come through and there's not enough repolarized cells in this area to allow for the signal to propagate, and it's going to get blocked. The reason this is important is because in a normal sinus rhythm you have a very specific pattern down here of cells depolarizing. What happens if this area right here gets blocked? Well, the first part of the ventricular depolarization as it goes through the His bundle and starts to travel down the right bundle branch is going to be this normal area right here. The problem is once this gets blocked, the left side will depolarize normally and then it has to slowly travel around to the right side, and that is going to cause your QRS to widen out. You can do the same thing. This is example number 1. Here is example number 2. So basically you have a P wave here, and the first few milliseconds of that QRS and that QRS are the same. They have the same direction, they have the same angle, they have the same vector, they have the same direction. That would tell me that this right here is not a PVC, it is an aberrancy. Let's talk about some rapid junctional rhythms. The first thing I want to talk about is the difference between a junctional rhythm, accelerated, and junctional tachycardia. First of all, any junctional rhythm that occurs between 40 to 60 beats a minute is considered a junctional rhythm. If you go above 60 up to 100, it's accelerated junctional rhythm. Any rhythm that depolarizes with a ventricular rate of greater than 100 is always called tachycardia. For example, sinus tach, junctional tachycardia, and even ventricular tachycardia. Ventricular tachycardia has a ventricular rate of over 100 beats a minute. Any rhythm over 100 is considered tachycardia. In this case, junctional tachycardia is a junctional rhythm that goes over 100 beats a minute. One rhythm it does not talk about on here is what happens if you have a junctional rhythm that is less than 40 beats a minute. Any rhythm that occurs less than its intrinsic rate is considered bradycardia. So if you have a sinus rhythm at 40 beats per minute, technically that's not a sinus rhythm, that's a sinus bradycardia. So a junctional rhythm that occurs at, we'll say, 30 beats per minute technically is not a junctional rhythm. It is occurring at less than the intrinsic rate, so it would be a junctional bradycardia at 30 beats a minute. We talked a little bit about this before in a couple of the rhythms. I told you that there were some little dips and bumps in areas that could be P waves and they could be something else. So let's talk about the pseudo S-wave and the pseudo R-wave. If you have a P wave that occurs right here, that could be a false S-wave. You're not going to necessarily know that's a P wave. If I were just to see this QRS complex right here, I might assume that's the Q wave, and that's an S wave, and then that would go into the T wave. I don't know that that's a retrograde P wave. The only way I would know if that is a retrograde P wave is if I convert the rhythm into a sinus rhythm, and that S wave goes away. Then I would know the S wave that I saw was a pseudo S wave because that was actually a retrograde P wave. Unless I convert the rhythm, I'm not going to be able to identify that. The same thing can happen in V1. If this is a P wave that is a retrograde P wave, I might not know that. So if I just look at this right here, I'm going to assume that's an R wave, that's an S wave, and that's an R prime wave. I'm not going to know that this is a retrograde P wave unless I convert the rhythm to a sinus rhythm. And if this bump goes away and it just goes across like this with a P wave in front after I convert it, then I'll know that that was a fake R wave or a pseudo R wave. Let's look at the characteristics of an accelerated junctional rhythm. Remember, an accelerated junctional rhythm is going to have a rate of more than 60 but less than 100 beats a minute, or around 60 to 100 beats a minute. Since it's a junctional rhythm, it's going to be regular. P waves, they could be absent if they're occurring within the QRS, or they could be inverted if they occur before the QRS. If they're absent, then they're not going to be applicable. There's no P to QRS ratio if you don't see a P wave. If they're inverted, you could say that the P wave is married to the QRS complex, but it's that's kind of a gray area. The PR interval typically is less than 0.12 seconds if it is present, and it could be absent. The QRS is going to be normal or it's going to be wide depending on the ventricular depolarization patterns. Remember, the problem with this rhythm is that it's above the ventricle, so the QRS width has nothing to do with the origin of the rhythm itself. Let's get an example of an accelerated junctional rhythm here. As you can see here, let's say this is a 6-second strip. What's our rate? 1, 2, 3, 4, 5, 6, 7, 8. So the rate is 80. That would be a ventricular rate. So that would tell me that because it's between 60 and 100 beats a minute, there's no P wave in front of it. That little bump here, that's not a P wave. That's just the line returning back to the isoelectric line. So that's definitely not a P wave. But you have this little line right here. There's no P wave, and it goes right to the QRST. So that tells me that the junction itself is the one that's firing off the intrinsic rate. It's 80 beats a minute, so it's going to be accelerated. If it were over 100 beats a minute, it would be considered junctional tachycardia. Speaking of junctional tachycardia, if the irritable focus in the AV junction or anywhere around there overrides the SA node and has a rate of over 100 beats a minute, it is considered a junctional tachycardia. Most of the time, this is an enhanced automaticity secondary to suppression of the SA node. So In this case, the AV junction is beating so quickly it is overriding the SA node and not allowing the SA node to do its job. The problem is that it has a loss of that atrial kick. That atrial kick, depending on the text you read, accounts for 20 to 30% of ventricular filling. Now, that doesn't mean that your cardiac output is going to drop by 20 to 30% because your ventricles can compensate by increasing their size, making themselves bigger, and then increasing the contractile force, how hard it actually pumps the blood out of the left ventricle. What that can do, though, by going into a junctional tachycardia, because it's a junctional tach, it can predispose a person to having some kind of ventricular dysrhythmias. Let's look at the characteristics of a junctional tachycardia. The characteristics are the rate is over 100 beats a minute, usually up to 130. Depending on the text you read, it can go up to 150. Sometimes it can go up to 180. It kind of depends on the text that you read. The regularity, since it's a junctional rhythm, it's going to be regular. P waves, absent or inverted. The higher up you go in the junctional tachycardias, though, I'll be honest, most of the time they're going to be absent. You're not going to be able to identify them unless you do a 12 lead. And if the person has some kind of hemodynamic compromise, you're not going to want to sit there and do a 12 lead and argue over junctional tach versus another supraventricular tachycardia. The P to QRS ratio is not applicable typically because it's absent. The PR interval, if it is present, will be less than 0.12 second. And of course, the QRS width is going to be normal or wide. Let's interpret some rhythms. In this case, the book where I got this rhythm showed that this was a P wave right here. It was a retrograde P wave. I don't want you guys to try to identify something like that because it can get you in trouble. So if you were to just look at this and say, what exactly is my atrial rate, since I can't definitively identify any P waves without previous EKGs, I'm going to assume that the P waves are buried somewhere in there, and I'm going to think, okay, I can't see P waves. So right now, for my atrial rate, I'm going to put unable to obtain or something along those lines. What is my ventricular rate? Let's pretend this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we'll say that ventricular rate is about 100 beats per minute. Let me see. If you start here, 300, 150, 100. So it's probably exactly 100 beats a minute. Regularity is going to be regular. P waves are going to be absent. If you don't have a P wave, you do not have a PR interval. The QRS complex, I don't know if this is a pseudo S-Wave or a retrograde P wave, so I'm just going to incorporate that into the QRS width, which is fine because that gives me 1, 2, that gives me about a 0.10 second. When I interpreted this on my own, the rate itself actually came out to 90 beats a minute. But I'm putting 100 beats a minute here. So ideally, if you want to put this down as an accelerated junctional rhythm, I would accept that. If you put it down as a junctional tach, I would accept that too. I would accept either one of those. If you did the actual calculation, though, you would have a 98 heart, oops, this would be a BPM, a 98, and in that case, it would be an accelerated junctional. I will tell you now, if you put 98 beats a minute and then put junctional tach, it will be marked wrong. But in this case, it would be fine. In this one, what is my atrial rate? Is that a pseudo S-wave or is that a retrograde P wave? I have no idea. I'm not going to try to identify either one. So I'm going to say that it's part of the QRS for now until I can identify it later with a 12 lead or converted rhythm. So I'm going to say that there is no atrial rate. It's unable to obtain. Ventricular rate, 1, 2, 3, 4, 5, 6, 7. We'll say using a 6-second strip that it is 80 beats per minute. The QRS complex looks pretty wide with this. I don't know if that's a pseudo S-wave or if that's part of the QRS complex, but 1, 2, it looks to be a little bit wider than 0.12 second, but we'll go ahead and, we'll say regularity is regular. P wave is absent. PR interval is absent because we don't have a P wave. QRS complex, I'm going to say is about 0.12 second. It could be a little bit wider, but I'm not really sure. What I would do, though, is in this situation, I would do a 12 lead. What is my underlying rhythm? It's at 80 beats a minute. It's regular, no P wave, so I would say that this is an accelerated junctional rhythm. The other one here, the next one, 24/3 rhythm, this one right here, is this a P wave right here or is it not? I don't know. So I'm going to assume that that is not a P wave and it is part of the QRS complex. So my atrial rate is none. My ventricular rate, 1, 2, 3, 4, 5, 6 is 70. Regularity, I don't have calipers, but I'm going to assume that it's regular. P waves, I'm going to say are absent. PR interval, don't have one since we don't have a P wave. QRS complexes, this is a really wide QRS. If you look here, this thing is almost 0.20 second. It looks like it, well, it might be 0.18, so we'll just put 0.18 second. I know for a fact that this is wide, whether it's 0.18 or 0.20. Interpretation, well, my underlying rhythm is going to be an accelerated junctional rhythm only because my heart rate is 70 beats a minute, my ventricular rate. This is really wide, and this is lead 2. Without doing a 12 lead, I would comfortably say that this might be a right bundle branch block, but I would definitely do a 12 lead on this person to figure out what the heck is going on with this patient. Next rhythm here. The book was nice enough with this arrow right here to show us that this is a retrograde P wave that is not part of the QRS complex, but what if you didn't have that arrow right there? You might not identify that as a P wave. You might assume that this is part of the QRS complex, and that's perfectly fine too until you get this rhythm converted. So let's look at this rhythm here. What is our atrial rate? We're going to say it's unable to obtain. The ventricular rate, if we use a 6-second strip, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So our ventricular rate is about 120 beats per minute if I do the 6-second method. If I do the calculations by the little boxes, the 1500 method, I come out to a heart rate of 135. If you were to actually do the calculation itself, it's 135. I'm not going to identify these as retrograde P waves because it's easy whenever the book tells me what it is. Is it regular or irregular? I'm going to say it's regular. P waves, I'm going to say are absent. PR interval, you don't have one since you don't have a P wave. QRS complexes, I can't tell what this is, so I'm going to say 1, 2, so I'm going to say 0.12 second. It's borderline. I would probably do a 12 lead anyway. So these are probably pseudo S-waves. Interpretation, since the heart rate is over 100, whether you use 120 or 135, the heart rate is over 100 and there's no P waves, I would call this a junctional tachycardia. I will tell you up front that there are books out there that say that any rhythm that is over 140, that is a narrow complex tachycardia, you want to consider that as AV nodal reentry tachycardia. That sounds like a lot of big words in there, but we will talk about AV node reentry tachycardia and atrioventricular reentry tachycardia here in a little bit. Just understand right now we're going to consider this as a junctional tachycardia. Next rhythm we're looking at here is very similar to the previous rhythm. The book was nice enough to identify this right here as a pseudo S-wave, is actually retrograde P wave, but we're going to pretend that we don't have little arrows, so how would we know what that is? Atrial rate is going to be none, or actually it's not going to be none, it's going to be unable to obtain. The ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. It says 120 if we use the 6-second method, but I did the calculations earlier and the heart rate is actually 135 again. Either way, it's over 100 beats a minute. Regularity is going to be regular. P waves are going to be absent. It's supposed to be an absent. PR interval is going to be none. QRS complex, this is really difficult to tell. Since the book is telling me that this is a pseudo S-wave right here, it's pretty easy for me to know that the QRS is nice and narrow. If it wasn't nice and narrow like that, it would be a little bit more difficult to tell. Is it normal? Is it wide? I don't know. But I would probably identify this as being part of the QRS complex, which would make it really wide. So I'm going to say that 0.12 second. Underlying interpretation would be junctional tachycardia. Let's look at our next one. This rhythm here is V1, which is the different lead of the previous EKG. So I'm just going to back up one right quick. This is the lead 2. This person did a 12 lead on this patient, and this is the lead V1 of that previous rhythm. If you do this 12 lead, now I can identify this right here. That is not a normal ST segment right there. You don't have ST segments that do that. So to me, that would identify that as a retrograde P wave, or in this case, a pseudo R wave, because that would be a pseudo R wave. So if I were to identify this, now I know that that is a P wave. I would still say my atrial rate has a number. How would you identify it? If you definitively knew that that was a P wave right there, then you could say the atrial rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, and we'll just say 10. The problem here is that if you just leave it like that, people are going to assume that your atrial rate is a normal atrial rate that occurs before the QRS. In this case, you can identify it as retrograde. So you do have a P wave giving you an atrial rate, but it is retrograde. Next, your ventricular rate, well, it's going to be the same, so we're going to call it 100 beats per minute. It's probably a little bit more than that, but we'll call it that for now. The regularity is regular. P waves, we can put present if you choose to identify that pseudo R wave as a P wave. You can put present, but you can't just leave it present. You have to identify present, but it is retrograde. If I were teaching this class, I would probably accept absent, because it's really tough to tell with one lead if that's a P wave. The PR interval, if we go with present and retrograde, it's still none, because a PR interval means the P wave occurs before the QRS complex. In this case, the P wave occurs after the QRS complex. So because the P wave occurs after the QRS complex, it is actually an RP interval. So we still do not have a PR interval. We have an RP interval. QRS complex, if we identify that as a retrograde P wave, we'll say the QRS is 0.08 second. In this case, because it's over 100 beats a minute, we would still call this a junctional tachycardia. Let's look at another rhythm here. Do you see P waves in this situation? I don't, so we're going to say that it's none. Not none. Unable to obtain. Ventricular rate, well, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We'll say 120. Regularity looks regular. P wave is absent. PR interval is none, because you can't have a PR interval without a P wave. QRS complex, they're narrow, steep angles, sharp points. I will say that they are 0.08 second. Interpretation, junctional tachycardia. Last rhythm. This right here, once again, we're looking at lead 2, so the QRS should be up, but it's not. This rhythm here looks like that might be a P wave, or it could just be part of the normal QRS. I don't know. I'm not really going to identify that as a P wave because I'm not really sure. So my atrial rate, I'm going to say, is none. I need to quit doing that. Is unable to obtain. It's not none. Ventricular rate, I'm going to take as 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we're going to say that it's 110 beats per minute. Regularity, we're going to say is regular. P waves, I'm going to say at this level is going to be absent. PR interval, there can't be a PR interval if there is no P wave. QRS complex, if I take this as part of the QRS complex, that would extend my QRS by one little box. So I'm going to say that's 1, where does it go? Here we go. 1, 2, 3. So I'm going to say that it's 0.20 second. Now the book might have identified this as a P wave before that, and if it is, then you wouldn't add that extra little box right there, that little slope. But we're going to go ahead and pretend that it's not a P wave and that it is part of the QRS. So the underlying rhythm is going to be junctional tachycardia. Next, we're going to discuss AV nodal reentry tachycardia. I will tell you up front, if you get this process of AV nodal reentry tachycardia as a pre-hospital provider, you're probably going to be heads and shoulders above a lot of other paramedics and other pre-hospital providers. This is something that has been taught for a really long time. It's just at a paramedic level, most of the time we just kind of stick with SVT. Previously, you may have been allowed to call a rhythm SVT. Once you go through this presentation in my class, you are no longer allowed to call a rhythm SVT, and I'll explain why that is. So let's talk about AV nodal reentry tachycardia. This is abbreviated as AVNRT. First of all, the term supraventricular tachycardia, or SVT, is antiquated. It is not accurate. It used to be that any time that you had a narrow complex tachycardia that was over 150, you automatically classified it as SVT. Fortunately, advancements in pharmacologic and surgical treatments and research has shown us that there are 7 different types of SVT that a patient can be in. Remember, if you identify what SVT is, supraventricular supra just means above, ventricular means you're above the ventricles. The last word, tachycardia. What do we mean by tachycardia? Heart rate over 100 beats per minute. So I will tell you right now, what is the most common supraventricular tachycardia? The number one supraventricular tachycardia is sinus tach. So let's say that somebody has a heart rate that is a sinus rhythm at 110 beats a minute. Is it supraventricular? Does it occur above the ventricles? Yes, it does. It's 110, so is it over 100? Yes, it is. So would you call somebody in a sinus tach SVT? And the answer is no, of course not. You wouldn't do something like that. So we're going to go ahead and discuss all of the different SVTs. The first thing I want to do is I want to list each one of the SVTs. And I'm not going to have room to do this, so we'll just kind of squeeze it in here. The first most common, and this is in the order of frequency, in order of how often they occur, the most common supraventricular tachycardia, sinus tach. The second most common SVT is atrial fibrillation. The third most common SVT is atrial flutter. The fourth most common SVT is what we're talking about right now, AV nodal reentry tachycardia. The fifth most common SVT is something called an atrial ectopic tachycardia. So it's basically atrial tachycardia. I'm going to have to move over here. The sixth most common SVT is a multifocal atrial tachycardia. And if you don't remember what that is, go back and review the atrial rhythm presentation, please. The seventh most common SVT rhythm is junctional tachycardia. In the past, when somebody has been in a supraventricular tachycardia or an SVT, you would do vagal maneuvers and then you would give adenosine. My question to you is this: how many of these rhythms does adenosine terminate? And the answer is only one. Adenosine will only terminate AV nodal reentry tachycardia. If you're in a sinus tach, AFib, aflutter, atrial tach, multifocal atrial tach, or junctional tach, you can give gallons of adenosine, and if it converts it, it's not because of the adenosine. It's not because it was with the AV nodal reentry tachycardias. The next question I usually get from a lot of people is, if I'm not allowed to call this SVT anymore, so you're not allowed to call it this anymore, what exactly do we call it? Well, American Heart calls it a narrow complex tachycardia, because that's truly what it is. It's a supraventricular narrow complex tachycardia. So they just call it narrow complex tach. If you have a person in a narrow complex tachycardia, the first thing you want to identify is it AV nodal reentry? And you can do that by giving vagal maneuvers or by having the patient perform vagal maneuvers and by giving a round of adenosine. That's perfectly acceptable. What happens if you have an atrial flutter with a 1-to-1 conduction? You give adenosine and you see the sawtooth pattern underneath, you're going to want to stop giving adenosine because you can give another 5 doses of adenosine. It's not going to convert atrial flutter. That patient needs different medication. So let's go ahead and move on about about AV node reentry tachycardia. Let's talk about the origins. AV node reentry tachycardia is a reentry tachycardia. It is a reentry problem. Where does a reentry problem come from? We've talked briefly about it before. We're going to talk about it a lot right now. There are 3 factors or 3 criteria that are needed for you to have a reentry problem. The first one is you need to have at least 2 separate pathways. What we're talking about here is here's your that's your SA node, that's your AV node, and we're going to talk about 2 separate pathways here. I know there's another AV node or internodal pathway here, but we're not going to talk about that. We're just going to talk about these 2 right here. For you to have an AV node reentry tachycardia that involves the AV node and the SA node, you need to have 2 separate pathways. Do you have 2 separate pathways here? Yes, you do. They need to have different underlying properties. Well, if you remember, this right here is a fast track. This right here is a slow track. Why is it the fast and the slow? Because they have different underlying properties. This slow track here, does it allow for slowing? Yeah, that's why they call it the slow track. So do you meet all of the criteria to have a reentry circuit between the AV node and the SA node? Yes, you do. Let's talk about where the reentry comes from itself. In 10% of the patients, they have 2 tracks which reach the AV node. In the other 90% of the population, the fast track will leave and make it to the AV node. The slow track will just terminate somewhere up here in the right atrium. But in 10% of the patients, this slow track makes it down to the AV node. Now, this causes a problem. What happens is the fast track will depolarize the impulse very quickly, and the impulse will reach the fast track and the AV node first. It always reaches it first because it's depolarizing faster. What will happen is the slow track, as it's depolarizing, it will take a lot longer to get down here to the AV node. What that does is it causes the fast track to depolarize the AV node, and then it will try to backtrack up the slow track. The problem is the slow track already has an impulse coming down. What happens when these two impulses meet in the slow track? They cancel each other out. In 10% of the population, this is what happens 99.9999999% of the time. There's never any problem. There is no clinical significance whatsoever. But what happens if there's a problem? When you develop the narrow complex tachycardia, you have your orange impulse right here, which is a normal impulse. What happens in the normal impulse? The signal is going to travel down the fast and the slow track. The signal traveling down the fast track is going to depolarize the AV node. It's going to try to come back up, and it's going to cancel out the signal. That's what's going to happen. But something occurs that throws this system out of sequence. There's your SA node, there's your AV node, here's your tracks, okay? We're going to pretend for a second that right here is a premature atrial complex. So when the normal impulse comes down and performs this procedure right here, the PAC is actually following along the slow track, making its way down to the AV node. When the depolarization of the PAC occurs, it spreads out in waves throughout the atrium. What happens if it depolarizes this slow track here? It's going to depolarize this one first before it depolarizes the fast track, which is going to send another impulse going down to the AV node by way of the slow track. What happens is, because it's traveling down the slow track, it's not traveling down the fast track. It's traveling down the slow track. What happens is it will depolarize the AV node, and then it will head back up the fast track. It will depolarize the SA node, and it will travel back down the slow track. So what happens is, because of this PAC that occurred right here, that depolarized that slow track prematurely, the impulse will travel down the SA node, or down through the AV node, and then back up through the SA node, redepolarize the SA node, and then back down the slow track, back up the fast track. And what did we just create? We created a circus reentry, or a circuit problem. Now we have a reentry tachycardia. How fast can this occur? Extremely fast. I didn't realize this for a long time, but if you ever look at somebody, and you might recognize this as a paroxysmal supraventricular tachycardia, PSVT. I never noticed it before until I started learning about this a little bit more, that every PSVT has a PAC that begins the paroxysmal supraventricular tachycardia. Once I went back and started looking at all my previous rhythms, I found a lot of those rhythms that had the PSVTs, there was a PAC before it, causing this circus reentry right here. In this example here, this is a normal sinus rhythm followed by an AV nodal reentry tachycardia triggered by that PAC. So we have our sinus beat, we have a sinus beat, we have a PAC that triggered this to go into this narrow regular paroxysmal tachycardia, or we call it narrow complex tach. One thing I want to point out is it says here that this is a pseudo S-Wave. How do I know that's a pseudo S-Wave? Look at this QRS and look at that QRS. Are they the exact same? And the answer is no. This little extra S-wave right here does not exist over here. There is an S-wave in that QRS, but it is much, much smaller, which tells me that this pseudo S-wave is probably a retrograde P wave. Am I going to try to explain this and decipher this on scene while the patient has a heart rate of 190? No, of course not. I can go back later and look at it and go, oh, look, there's a pseudo S-wave. That was your retrograde P wave. In the heat of the moment, just interpret the rhythm and treat the rhythm, especially if the patient is unstable. Later, you can go back and diagnose it and analyze. Normally, we have two different routes that this can take, or two different directions. Typical AV-NRT travels in a counterclockwise fashion because normally what happens is the signal travels down the slow track and up the fast track. This is a normal depolarization pattern that occurs when somebody goes into this narrow complex tachycardia. Is it possible for it to travel clockwise? It is possible for the signal to travel clockwise. It's not very common though, that's why they call it atypical AV-NRT. So what will happen is the wave will come down the fast track and it'll go really slow up the slow track to get back to the SA node. How can you identify this on the monitor? Look at the retrograde P wave and see how close it is to the QRS complex. If the retrograde P wave is smashed up against the QRS complex, it's typical. If the retrograde P wave is displaced after the QRS complex, it's atypical. Like I said, in the heat of the moment, just treat the patient. Worry about if this is typical versus atypical AV-NERT later. Do that after the patient has been converted. Let's look at the characteristics of AV nodal reentry tachycardia. First, the rate, depending on the text you read, is somewhere between 140 and 250. Okay? If it's narrow complex and over 140, there are people out there that will treat it because unless there's some kind of other situation like a dehydration, heat exhaustion, fever, recreational drug use would be a good one. If somebody has a heart rate of 150 or 140 to 150, but they've been doing recreational drugs like amphetamines or methamphetamines, then we're probably not going to treat that because it doesn't matter. It's a pharmacologic problem. It's not a re-entry problem. But if you suspect that it's a re-entry problem and it's over 140, consider the possibility that you could do vagal maneuvers in adenosine to see if it would convert it. When it's really fast like that, it's going to look like it's regular. If you have a P wave and you can identify it, then it'll probably be inverted and retrograde. But most of the time, it's really tough to identify P waves. So just consider it absent. If you do have P waves, it'll be a 1-to-1 P wave, 1 P wave for every QRS ratio. If you do have P waves, it'll, like I said, it'll be retrograde, so it'll probably be an RP interval, not a PR interval. Otherwise, if you can't see it, then it's just going to be none. QRS width, normally the QRS is normal. If we're talking about AV nodal narrow complex, the QRS will be normal. Unfortunately, it is possible to have an AV nodal reentry tachycardia with a wide QRS, and we'll talk about that later. So the first rhythm we're going to identify here, where exactly is the P wave? I can't tell. So I'm going to say the atrial rate is unable to obtain. What is my ventricular rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So my atrial rate, my ventricular rate is 180 beats per minute. You think this person's going to have some chest pain and fluttering? More than likely. Regularity, we're going to say is regular. P waves are going to be absent. PR interval is going to be none. QRS complex, even though this is going so fast, look at that. This QRS complex looks normal, so it's going to be 0.08 second. Interpretation. If you put, I will tell you now, if you put SVT as your interpretation, you will get that wrong. I will mark off points for that. Please understand that from this point forward in my class, I do not want you to put supraventricular tachycardia. We are going way past that. Now, can you identify what this is? Is this an atrial fib or an atrial flutter? Is this avnert? Is it junctional tach? We can't tell. At this point, you could call this a narrow complex tachycardia, and I would accept that. Let's identify this, though, as avnert, because we're talking about that. If you remember the difference between typical and atypical avnert, typical, the P wave is smashed up here into the QRS complex. Atypical, the P wave is displaced. Is this a normal T wave or is that an abnormal T wave? I don't know if that's a normal T wave or not for this patient. So I don't know if this is typical or atypical. If you put narrow complex tachycardia, though, you'll be fine. In the next rhythm here, the book, once again, was nice enough to identify that right there, and that little bump right there is the retrograde P wave. If you could not identify that on the monitor because the monitor doesn't point out where the P waves are, it just doesn't give you little arrows. So let's say that we cannot identify the atrial rate. So we're going to say that the atrial rate we're unable to obtain. What is our ventricular rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So we're going to say that the ventricular rate is 190 beats per minute. Regularity we're going to say is regular. P waves. Since the book is pointing out that these are retrograde P waves, we can see them now, but if it didn't point that out, we wouldn't be sure really what that is. So we'll say P waves, in this case, are absent. If you can identify those as P waves, then you can put retrograde. PR intervals, none. You can't have even if it's retrograde, you can't have a PR interval because then it would be an RP interval. QRS complexes look to be nice and narrow, 0.08 second. Like I said, I'm estimating the QRSs because I don't have calipers. The interpretation, if you want to play it safe, narrow complex tachycardia. That's how you can identify these and you would be perfectly fine. Now let's look at this a little bit more in detail. We do know that these are P waves because the book is telling us that those are P waves. Due to that, would this be a typical or atypical avnert? Since the P waves are smashed up against this QRS complex, I'm going to say that it is typical AVNRT. Is that going to change my treatment plan at all? And the answer is, of course not. It's not going to change a single thing about my overall treatment with the patient. Not going to change it. Identifying it later, though, really does make you look like a rock star, and it kind of gives you a little bit of respect if you can identify that. Let's look at the next rhythm here. This rhythm here is the lead V1 of the previous rhythm strip. I'm just going to back up one. This is lead 2 of this rhythm. This is the same rhythm, but this is just lead V1. So the atrial rate, it's pointing out right here. This is my atrial depolarization right here. If we didn't have that, we'll just go with absent or unable to obtain at this time. Ventricular rate, what did we say before? It was 190 beats per minute. That was one, since this is the same rhythm. Regularity, once again, is going to be regular. P waves, ideally, I would probably put absent, and I would accept absent if you put that. In this case, though, since the book is pointing it out, which you're not going to have on your homework or your tests, you could say that the P wave is retrograde. PR interval is going to be none. You can't even have it if it's retrograde because it would be an RP interval. QRS complex, I think we said was 0.08 second, which makes it normal. Interpretation, we could comfortably say that this is a narrow complex tachycardia. Otherwise, based on the 12 lead, I know that that's going to be a retrograde P wave. Since that is a retrograde P wave there, I know that is typical. Avnert. This rhythm here can't identify any P waves whatsoever, so I'm going to assume that they are hidden or absent. So I'm going to put unable to obtain. My ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 170 beats per minute. Regularity is going to be regular. P waves, absent. PR interval, none. The reason I put P waves are absent, I can't even identify a possible pseudo S-wave or pseudo R-wave. Well, it's lead 2, so it'd be a pseudo S-wave. I can't identify that at all. So I'm going to go ahead and assume that it's completely absent. QRS complex does look nice and narrow, though, at 0.08 second. Comfortably, you could be safe and call this a narrow complex tachycardia. Would you identify this, though, as typical or atypical AVNERT? I wouldn't be able to identify either one of them because I have no idea what it is. I have no idea where the Q wave, or I'm sorry, the P wave might actually be. This rhythm here is the same as the previous rhythm strip. It's just in a different lead. This is in V1 right here. And what they did was they found this extra little bump up here on the QRS whenever they did a 12 lead. So the book says that this is a retrograde P wave. If it is, then you would be able to identify this as typical AVNERT because that P wave is smashed up against that QRS complex. If it's displaced away from it, it would probably be atypical. So let's look at our atrial rate. Unless we know for certain that's what that is, I'm going to go ahead and just call that unable to obtain. Ventricular rate previously was 170. Regularity, it's going to be regular. P waves, in the perfect world, I would probably say absent. But because the book is showing me those, I'm going to say they're retrograde. Just to let you know for my class, please do not put absent and retrograde. You can't put both of those together. They need to either be absent or they need to be retrograde. And if they're retrograde, you need to identify where they are. You can't just put retrograde and hope that you're right because it will be marked wrong. PR interval, either way, is going to be none because if they're absent, you don't have one. If they're retrograde, you have an RP interval. QRS complex is nice and narrow, 0.08 second. Interpretation is going to be a narrow complex tachycardia, but if we know that these are P waves right here, we could call it typical AVNRT. On this one here, it looks a little irregular, maybe a little bit harder to define. The atrial rate can't really identify P waves, so we're going to say that they're unable to obtain. The ventricular rate itself, I already calculated, was 200 beats per minute. Regularity, it looks a little bit irregular, but it's very, very close to being regular. So we're going to go ahead and call this regular. P waves are going to be absent. PR interval is going to be none. QRS complexes, they look a little wide. They're kind of pushing. See how it's slurring out just a little bit right here? So the QRS complex might start looking like it's trying to delay in the conduction system in the ventricles because it's so fast. The signal isn't getting through the ventricles as quickly as we would like it to. So we're going to go ahead and call that 0.10 second for the QRS complex. The interpretation, we could be safe and call it a narrow complex tachycardia. What did the book do with this? It's really difficult to tell, but in the book, it was saying that it looks like that there are some extra deflections in here. See these little extra deflections? I would be uncomfortable just definitively saying that those are retrograde P waves. The book was saying that these are probably retrograde P waves. If that's the case, let's say that those are retrograde P waves. Would this be typical or atypical? AVNRT. In this case, the P wave is displaced so far away from that QRS complex that this would be considered atypical AVNERT. Is this going to change your treatment plan? And the answer is absolutely not. You would still perform vagal maneuvers. You would still perform adenosine if necessary. If the patient was unstable, you would still perform synchronized cardioversion. Couple more rhythms here. This is, we don't identify a very definitive atrial rate here, so we're going to say it's unable to obtain. Ventricular rate, I calculated previously, is 190 beats per minute. Regularity, I'm going to eyeball it and say that it's regular. P waves, I'm going to say are absent. PR interval is going to be none. The QRS complex, if I had calipers, I could be a little bit more precise, but I'm going to say it's 0.08 second. Interpretation, we could play it safe and call it a narrow complex tachycardia. In the book, as I was identifying this in the book and reading up on the literature, it was saying that there's another little deflection right there. Let's pretend that is a retrograde P wave. That would make this typical or atypical AVNERT. In that case, it would make it atypical, CAL, but I don't know for sure. But if it were, we would call it atypical AVNERT. How could you identify that? Well, do a 12 lead. You can also convert the rhythm to a normal sinus rhythm. If you convert this to a normal sinus rhythm and that extra little bump right there goes away, then you know that that was a P wave and you can call it atypical AVNERT. Last rhythm. Atrial rate is unable to obtain. Ventricular rate, we have about 190 beats per minute. We calculated that earlier. Regularity, it's going to be regular. P waves are going to be absent. PR interval is going to be none. QRS complex, it looks like the QRS complexes are nice and narrow, so it looks like a 0.08 second. It looks pretty good. Interpretation of this is going to be safely a narrow complex tachycardia. If you look at this closely, it has kind of a wavy baseline here, so it kind of goes up a little bit. There's a little dip right there, a little dip, so it almost looks like an electrical alternans. This might be an underlying rhythm of an atrial fib. I don't know. I can't tell. But it doesn't matter if this is a fib. It doesn't matter if this is AVNERT or atrial flutter. It's all going to be narrow complex tachycardia. Because we're talking about AVNERTs, this is more than likely typical AVNERT, but we can identify that. We have to convert the rhythm and then look back. Now let's talk about AV reentry tachycardia. This is going to be different. We just talked about AV NRT. This is different. It is AVRT. AVNERTs occur between the SA node and the AV node, where the signal goes around and round between these two nodes. In AVRT, you don't use the SA node. It uses the atrioventricular septum and the AV node. And what makes it interesting is now you have an accessory pathway that causes the circus reentry problem. So let's talk about the accessory pathway. In this case, we're going to pretend that this is our AV septum. This is the non-conductive wall that separates the SA node and the AV node. That separates the atria and the ventricles. The His bundle is the little bridge or the tunnel that goes through that. What happens if there's an accessory pathway over here that bypasses the atrioventricular node and the AV septum itself? The signals will travel this way. They're being slowed down through the AV node, but they're just going to travel right through that accessory pathway right there. Can you see this on the monitor? And the answer is yes, you can. Very commonly, we call that a delta wave. What will happen is you'll have a P wave that occurs normally, and then what the machine will read is the signal trying to depolarize the left ventricle early. But because it's going from myocardial cell to myocardial cell, it goes a lot slower because it has to account for muscular contraction. What that does is it causes the deltaing or the sloping of the QRS complex. Now, it's supposed to be nice, tight, narrow, steep angles and all this kind of stuff, but we have this sloping right here. That sloping right here that causes this delta wave is this impulse slowly traveling through the ventricle. Now, what happens next is pretty interesting. The AV node is holding the signal while this is slowly depolarizing. Once the AV node hits that trigger point and that impulse rifles through, it actually catches up and then cancels that signal out. Once it does that, that's when the narrowing of the QRS is occurring. So it starts out as a sloping, as an abnormal depolarization of the ventricle, but as the AV node releases that signal at the trigger zone, it rifles through the ventricles and causes a normal QRS complex. So now we have a reentry circuit. Consider this. What are the three causes of a reentry circuit? First, you have to have two separate pathways. You have to have two paths. This is a path, and that's a path. This is a path, and that's a path. Do we have two separate pathways? Yes, we do. What's the second criterion for a reentry circuit? Different properties. Does the AV node have a different property than an accessory pathway? Yes, it does. Let's consider the third criterion. Whoops. It's supposed to be slowing. L-O-W. The different properties cause a slowing. Does the AV node cause a slowing of it compared to the accessory pathway? Yes, it does. So now we have met all three criteria for a possible reentry circuit. There's two separate pathways. One of them is it goes normally through the AV node and then backwards through the accessory pathway. The other one is it goes through the accessory pathway and then backwards through the AV node. Consider, how did we identify AV NRTs? We identified them as clockwise or counterclockwise. AVRTs do not use clockwise or counterclockwise. AVRTs use the relation of the signal to the AV node. The reason for that is because if you look at picture B up here, it's going through the accessory pathway and then backwards through the AV node. That is abnormal. What happens if you have an accessory pathway over here? The signal will go through here. It will still go through backwards through the AV node. So you can't use clockwise and counterclockwise because the accessory pathway could be anywhere. So it uses the relation of the signal to the AV node. If it's backwards, it's abnormal. If it's forwards, it's normal. It's not normal and abnormal, but just go with it for now, and I'll explain the difference here in a second. The first AVRT I want to look at is called orthodromic. Orthodromic is the impulse travels normally through the AV node. So what happens is the signal travels normally through the AV node. It gets through the AV node, travels down the superconductive pathways, and then the impulse will travel retrogradely through an accessory pathway, back through the atria, back into the AV node. Remember, this is your atrioventricular septum. So you have this non-conductive wall here, a non-conductive wall here, but you have that accessory pathway that it's allowing the signal back through again. This will result in a narrow complex tachycardia. This will result in a narrow complex tachycardia because the signal travels normally through the AV node, through the normal bundle branches down to the Purkinje networks, and whenever it gets down to the Purkinje networks, the impulse doesn't stop, it continues back through the accessory pathway. What initiated AVNRTs, your AVNRTs? It was originated by a PAC. Why? Because everything was supraventricular. In this case, orthodromic AVRTs can be initiated by a PAC or a PVC. So you could have a premature ventricular complex occur here, and it could also cause this reentry circuit to occur. The AV node has a particular influence over the conduction system. So the AV node, if it's able to slow down the signal enough, it can self-terminate. Sometimes it doesn't, though. A lot of times these people are hemodynamically stable, and there's no delta wave when in the narrow complex tachycardia. Once you convert this, are you going to have a delta wave? And the answer is yes. You will have a delta wave when it is beating at a normal heart rate. When it is beating like this, you will not have a delta wave because you only have one signal causing the reentry circuit. So you will have, once again, down here, a narrow complex tachycardia, and adenosine would convert this too because adenosine works on the AV node blocking the signal, and it would block that reentry and it would convert the rhythm. Orthodromic AVRTs. Orthodromic AVRT is a narrow complex tachycardia. Atypical AVNRTs are also a narrow complex tachycardia as well. The difference is in the atypical AVNRTs, what will happen is your P wave will be retrograde here, retrograde P wave, that's displaced behind the QRS, which makes it typical. And this down here, picture number 2, this is orthodromic AVRT. But what happens here is you have almost the exact identifiable rhythm as an atypical AVNRT. How do you determine, after you convert this, how do you determine if it was AVNRT or AVRT? If you convert atypical AVNRT, you're going to have a P wave and a normal QRS and a normal T wave. If you convert orthodromic AVRT, because the AVRT has that accessory pathway, you're going to have a P wave and then you're going to have a delta wave going into a T wave. So if you convert the rhythm, a narrow complex tachycardia, if you convert it and it becomes a delta wave in the QRS with a normal heart rate, it's orthodromic AVRT, this tachycardia. If you convert the tachycardia and you have a normal sinus rhythm without any delta wave, then you converted atypical AVNRT. What is the abnormal depolarization? So we talked about the normal depolarization through the AV node, going this way, and it would go backwards to the accessory pathway. What happens if the signal travels through the accessory pathway, through the ventricles, and then backwards through the AV node? What happens if you have a backward depolarization through the AV node? Think of it this way. If the signal travels through the AV node and then through all of the normal conductive pathways to the Purkinje fibers, it's going to have a very narrow QRS. What happens if it travels backwards on that conduction system? It's going to try to travel cell to cell to cell as it goes through here, and it has to take the time for muscular contraction before it gets up here to the AV node. What is that going to do to your QRS? It's going to make it wider. So what will happen is you will end up having a wide complex tachycardia, not a narrow complex tachycardia. Antidromic AVRTs are wide complex tachycardias. When this was first published, one of the things that they used to say is that the wrong pharmacology may worsen this. Okay? And you always treat it as VTAC. I will tell you now, this is no longer the case. If you have a person that has a wide complex tachycardia and the patient is stable and the wide complex tachycardia is regular, then you're allowed, according to American Heart, to treat with adenosine. It is okay to give a round of adenosine to see if it will convert. If it doesn't convert, then you want to start working on other treatment plans. If it's wide and regular and the patient is unstable, you're going to cardiovert the patient anyway. Well, let's look at some rhythms. Fortunately, the book was nice enough to show that we have a QRS down here with a retrograde P wave. It's really easy to identify that when the book points it out, but we're going to pretend that we don't see any P waves down here because we're not going to always have that nice little blue arrow to show us where that stuff is. So we're going to say the atrial rate is unable to obtain. The ventricular rate I calculated before was 180 beats per minute, so we're going to go with that. Regularity, it looks regular. P waves are going to be absent. PR interval is going to be none. Since we don't have a P wave, we can't have a PR interval. QRS complex is going to be, looks like it's nice and narrow. If I had calipers, I would probably say 0.08 second is what I'm going to estimate it. What is my underlying rhythm? Well, you could be safe and call it a narrow complex tachycardia, and you could treat this with adenosine. If the patient was stable, you could treat this with adenosine and vagal maneuvers. Let's go with what the book says and say that that is a retrograde P wave under there. If this is a retrograde P wave right here, then it looks like that P wave is displaced away from the QRS complex. Because it is displaced away from the QRS complex, it can either be atypical AV NRT, or it could be orthodromic AVRT. How do we determine which one of those it is? We can't do it right now. We have to identify this after we convert the rhythm. So let's just say for fun, we give the person adenosine because vagal maneuvers were unsuccessful. The converted rhythm, we see a P wave with a delta wave and then going into a T wave just like that. If that was the converted rhythm, then we would say that this tachycardia is actually orthodromic AVRT. Let's say that we tried vagal maneuvers and we did not convert the rhythm with vagal maneuvers, but we gave adenosine and the converted rhythm was a normal P wave, QRS, and T wave. If the converted rhythm was a normal QRS and T wave, then we would say that this tachycardia was atypical, AVNERT. Like I said before, is it going to change your treatment plan? More than likely it won't in the emergent pre-hospital or in-hospital setting. Let's look at our next rhythm here. Is this a, do you see any QRS, do you see any P waves down here? We don't. So we're going to say that it is unable to obtain. Ventricular rate is about 160, which is what I calculated previously, beats per minute. Regularity, it looks regular. It's supposed to be an L. There we go. P waves, I'm going to say are absent. PR interval is going to be none. QRS complex. It's kind of interesting because you see you have that little extra something going on down there. Is that a P wave? Is that, I can't identify what that is. Um, but we would go ahead and identify that as a QRS complex. It looks narrow, so we're going to say 0.08 second. Not really sure exactly what this is, and I'm going to have to correct this because the book that I got this out of identifies this as a wide complex tachycardia. So it is saying that this is actually wide. So I'm going to say 0.16 second just for sake of going along with what the book says. How would we identify this? We would go ahead and identify this as a wide complex tachycardia. Would you give this adenosine? You could. If the patient was stable, it is regular, it is a wide complex tachycardia, you can try vagal maneuvers while you're preparing the adenosine and give adenosine. I will let you know, if adenosine does not work, you kind of have to start moving in another direction. You can't just keep giving adenosine and hoping that it'll work eventually. Since this is a wide complex tachycardia, according to the book where I got this, the notes were saying that the patient was actually converted from this rhythm, and once they were converted, the new rhythm had a P wave with a delta wave and a T wave. Because of that conversion, now you can definitively say that while they were in this wide complex tachycardia, you can now say that they were actually in a antidromic AVRT. But I can only identify that after I convert it and then witness the delta wave in the sinus rhythm. The next rhythm here, as we can see, we don't see any kind of atrial rate, so we're going to put unable to obtain. It's supposed to be a U. The ventricular rate that I calculated previously was actually 250 beats per minute. Regularity is going to be regular. P waves are going to be absent. PR interval is going to be none. QRS complex is going to be narrow for sure, so we'll just say 0.06. It looks like it's really narrow. Second, don't forget to identify your numbers. Interpretation, well, it looks like it is narrow, so I'm going to go ahead and call this narrow complex tachycardia. So let me ask you a question. Is this AVNRT or AVRT? Is this AVNRT or AVRT? We can't identify it right now. So if the patient is stable, you would perform vagal maneuvers and adenosine. If the patient is unstable, you can go ahead and consider synchronized cardioversion. This patient was unstable. So after cardioversion, this patient showed a P wave followed by a delta wave. What that means is this narrow complex tachycardia was actually orthodromic AVRT. Couple more rhythms here. So we have an atrial rate. I don't know what the atrial rate is. The book, once again, was nice enough to give me that little blue arrow right there and show me that that little spot right there might be a P wave. We would not be able to identify that definitively right now, but we would say that the atrial rate is going to be unable to obtain. I previously calculated the heart rate, the ventricular rate, which is about 250 beats per minute. Regularity is going to be regular. P waves. We don't identify P waves unless you want to use the book, which unfortunately we're not going to have little arrows on our 12 leads to show us where the P waves are. So we're going to say that the P waves are absent. The PR interval is going to be none. QRS complexes, these start to look a little bit wide. It would be really tough to tell where exactly it is. So the book identified these as wide QRSs. It would be great to be able to do a 12 lead and have the computer calculate the QRS so that we don't have to. But we're going to go ahead and consider this. We'll say this is 0.14 second just for fun, just to identify that it is wide. The interpretation then would be a wide complex tachycardia. According to the book, after this rhythm was converted, they found that the patient had a converted rhythm of a P wave with a delta wave into a QRS and a T wave. That does not make this just wide complex tachycardia anymore. That would now make this antidromic AVRT. That's what the tachycardia is. A tachycardia is antidromic AVRT. The converted rhythm is a sinus rhythm with a delta wave, possibly a WPW. The last rhythm here is kind of an interesting one. This one here would freak out a lot of people on scene and in a hospital, which it rightfully should. You shouldn't look at something like this and go, ooh, cool. You should look at this and start saying, we need help. This is a wide complex tachycardia. As you can see, automatically it's a wide complex tachycardia. The atrial rate is unable to obtain. Ventricular rate that I calculated previously was about 250. I think it was a little bit slower, but I think that's what my notes say here. Regularity is going to be regular. P waves are going to be absent. PR interval is going to be none. The QRS complex is really difficult to tell, but it actually starts right here and it ends right up here. So either way, it's going to be wide, so 0.16 second in this case. The interpretation we know is a wide complex tachycardia. I like this rhythm in the presentation because in the past, if you saw this rhythm, you would automatically treat it as VTAC, automatically. You would start giving antiarrhythmics, ventricular antiarrhythmics, and that kind of stuff. Let's pretend that this patient came in with a fluttering in his or her chest, and you put the person on the monitor, and this is what you see. Their blood pressure is stable, mental status is good, skin signs are great, they have great radial pulses. Paint the picture. All they have is this fluttering in their chest. Since the patient would be considered stable, you could say, let's try adenosine and see if it will convert it. According to the book, that's what they did. They tried adenosine first to see if it would work, and it did. The converted rhythm that they found on this patient was an S-wave, or I'm sorry, a P wave with a delta wave into QRS and a T wave. So it automatically shows that even when you see something like this, it actually could be an antidromic AVRT because it's a wide complex tachycardia. That concludes the presentation of junctional rhythm.